Right. Thank you all so much for joining us today for the next in our series of free educational webinars that we put on as part of the US Grade Network. So this webinar will be discussing guidance on using grade to assess certainty of evidence for prognostic factors with Dr. Farid Farrotan. We will have a discussion and presentation by him and then followed by question and answer. So feel free to put any of the questions you have in the chat, or if you'd like to hang on to them and then unmute after, feel free to do whatever feels best to you. I do want to make sure that you're all aware that we have many ways that you can keep in contact with the US Grade Network to make sure that you're aware of all of our upcoming webinars in the future, as well as other events and workshops that we do. So you can find us on Facebook at US Grade, on Twitter or X on US Grade Net, and then Instagram at Evidence Found. This is actually the first in a series of fall webinars that we are putting together. So I just wanted to make everyone aware of our upcoming webinars. The next one will be on the 21st of October and presented as part of World Evidence-Based Healthcare Day. And that will be the Evidence to Decision Framework for Environmental and Occupational Health, which is a new grade guidance that was just released earlier this year, led by the first author of that guidance, Emily Senerth. So after this, I will actually put that registration link in the chat so that you can definitely have that on your schedule to join us next month as well with Emily. Finally, I did want to make sure everyone was aware that next month, at the end of next month, we'll be hosting our 21st grade guideline development workshop. So we do these twice a year. Ever since 2020, we've been doing at least one virtually and one in person. So if you're joining us from anywhere in the world today, virtually via Zoom, you can certainly join us for 3 days for our grade guideline development workshop. We go all the way from coming up with a clinical question to assessing certainty of evidence using grade and developing and formulating recommendations from that. We do have a limited number of spots still remaining. We cap this virtual workshop to allow for small groups that are engaging and, high touch so that everyone has a chance to learn along with us and our experts. So this workshop will be October 29th, which is some of our pre-workshops we hold the evening before, and then October 30th through November 1st. So it's a 3-day event. We'd love to have you join. You can learn more at gradeconf.org. And I will put that link in the chat as well. Part of the exciting thing that we do now is we are working with InGuide to also offer InGuide Level 1 and Level 2 certification. So these are certification courses that can make sure you are fully prepared and certified either as a guideline panel member for Level 1 or a guideline methodologist for Level 2. So we actually have options as part of our 3-day workshop to access these at a reduced cost for you. So you can get the benefit of our 3-day workshop in addition to access to InGuide certification. Last but not least, this video is being recorded and will be uploaded to our YouTube as well. And this is where you can go to find any of our previous webinars you may be interested in, or if there's a webinar that you aren't unable to join live, you'll be able to find that basically the next day. So if there's any webinars in the past or coming up that you may not be able to see live, feel free to find our YouTube channel and enjoy the content there. And with that, I'm going to turn it over to my colleague, Reem Mustafa, who will be introducing Farid.
Thank you, Madeline. And hello, everyone. Good day. It's really great to see many of you, either your faces or your names, and connect with you. It was great to also see many of you in the Global Evidence Summit last week, which was great to see truly the community of evidence-based medicine from around the world come together. It is my absolute pleasure to introduce Dr. Farid Farrotan for this webinar. Dr. Farrotan is an associate scientist at Ted Rogers Center for Heart Research and an assistant professor at McMaster University. He completed his PhD in 2019 under the supervision of Dr. Gordon Guyatt, And his prominent focus has been on prognostic research, but now also interested in guideline. He's actually has considerable experience with working with multiple guidelines. And I always say Farid is one of the most thoughtful rising stars I've ever worked with. Really, really nice discussions and deep thoughts about how to move methods forward. And prognosis is one of those areas, just similar to diagnosis, many people don't want to touch. So we're hoping with our webinar today, Farid will make it easier for all of us to think about that, and exactly how does that intersect in any way with the guideline development. Farid, thank you so much for being with us today, and I turn it to you.
Thanks so much, Reem, and thanks to the US Great Network for hosting me and allowing me this platform to share some of the work that we've been doing over the last couple of years on prognosis related issues. Hopefully everybody sees my slides. Perfect. And so I just wanted to take this opportunity for this workshop today to give some of the latest thinkings that we've been having with the Great Prognosis Working Group around how do we tackle these very complex things called prognostic models that often become the subject to even folks who are developing guidelines, and they want to use them to help them in the stratification of the patients based on their baseline risk, and perhaps making different recommendations for folks that fall into different risk categories. But the foundation of them is to be able to understand these prognostic models, the evidence that's accumulated with regards to their performance in different types of cohorts that have evaluated these models. And so the plan of action, hopefully for today, if time allows, is to give you all an introduction to these prognostic models, which is the most complex form of prognostic questions that one can be focused in, introduce you to some of the metrics around how we evaluate the model performance, like the discrimination of the models, and some of the new great ways of thinking around what do we do with these measures of discrimination, how do we draw conclusions from them to set up what our target of certainty rating becomes. Give you an introduction to another performance metric that's often the focus of this type of research called calibration. And then also the great concept paper number 2 that tended to focus on looking at how do we make inferences from the calibration of these prognostic models as well. It's going to be hard for me to see the chat. So if anybody at any time has any questions, I'm more of an interactive person who likes to give talks, so feel free to raise your hand or interrupt me and ask your questions, and I'd be happy to answer as we go along the presentation.
And Farid, if anything in the chat, I'll alert you.
Thanks so much, Reem. Appreciate that. So, all right, with regards to prognostic models, let's all make sure that we have a good foundation to start off from. These are complex forms of algorithms that we're putting together, and they tend to combine various individual prognostic factors, either a patient disease characteristic or some sort of information about the patient, together in some sort of an equation that allows us to output what the predicted risk of a future outcome is going to be for that individual patient who's in front of us, and we're evaluating them with this prognostic model. So the simplest form of this is on the left-hand side of the screen. This is the Seattle heart failure model. It's a very traditional biostatistical model in the area of heart failure, where you can see that you have these traditional features or information that you grab from the patient, like their age, their gender, New York Heart Association classification, their ejection fraction, typical things that we get from a clinical examination. And we know how much each of these individual factors is associated with risk of mortality at some follow-up time in the heart failure patients. And by knowing the individual contributions of these factors, we can put them together in a formula, and that formula at the end will output what the predicted risk of mortality is, depending on the different interplay of these factors. So for a given age, for a male who has an ejection fraction of, let's say, 35%, and maybe they're on ACE inhibitors, you can get a very specific probability that's going to be quite different than somebody else who you come across at a different age, who may be a woman, who their NYHA classification is completely different. So this is the most simplest form of prognostic models, and this is by and large has been the focus prior to the development of artificial intelligence, or the not the development, but rather the rise of artificial intelligence and machine learning in the field of medicine. Nowadays, there is a lot of interest in machine learning and deep learning models. And all there is to it is that there are different formulation of how we put the prognostic models together. So with machine learning, you may still have your tabular traditional data that you're used to seeing, like the same sort of inputs that we had with the traditional biostatistical models. But the way that you put the model together, the weights that you assign to different features starts to look a little bit different. But the goal is still the same, is to output the predicted probability of the individual patient who you come across. Deep learning models, they're a lot more advanced, and it's not so much around tabular data, but they've really become powerful and helpful when we have higher dimensional data. Like, for example, if you have echocardiography on your patient, or if you've done auscultation of the heart and you have those audio files, you can use those as feature inputs to your model and use that to inform the predicted probability of the patient. And it becomes really powerful because it's not so much around the knowledge that we currently have. The model itself can help you in extracting features from the routine tests that we do and deploy on the patients who we come across in our clinical practice. Irrespective of which of these types of models you come across, in medicine, we tend to see two statistics being commonly reported across the studies that focus on prognostic models. One of them is the discrimination of the model, which is on this graph on the left-hand side. This is your traditional area under receiver operating curve, where if you're looking at this line, which is the light blue line called C, this is a 45-degree angle. It represents an area under the curve of 0.5, where we jokingly but actually seriously say it's like flipping a coin to decide who's going to be high risk, who's going to be a low risk patient. Whereas A, if you had this orange line, that would be a perfect model where it's a perfect classification of the patients and differentiation and separation of those who are high and low risk. But sometimes what we see is something in the middle with the darker blue color, and we have to somehow make sense of this as to what this is telling us with regards to how well the model is performing. And we always want to see better and better, where this blue line is becoming closer to what A is representing. The other concept that's commonly reported on these prognostic models is calibration. And calibration is effectively the agreement between what the model predicted the risk to be versus what the actual observed risk is to be. And I'm giving a very high level definition here. I'm not going into depth, but the upcoming slides, we're going to go into a lot more depth into what these concepts represent and what's the actual definition behind them, how do we make sense of them and try to draw conclusions and make them the target of our certainty rating when we proceed with the grade assessment. Okay, so with regards to certainty and prediction models, we're currently developing grade guidance on how do you assess your certainty in the performance of these prognostic models that you're going to come across in a body of validation studies. What we're rating our certainty in is in the discrimination statistic that we see, which was the graph on the left-hand side of the previous slide, and also calibration, which was the concept on the right-hand side of the previous slide. And we're going to have to do our grade assessment in each of these separately. And if I were to draw analogies between what we're doing in prognosis and what folks are doing in diagnostics, Reem's the expert here, so I have to be careful about what I really say here, but we do tend to look at sensitivity, specificity separately when we're evaluating diagnostic tests. If you were to draw a parallel seal here, we would rate our certainty and discrimination separately, and we would rate our certainty and calibration separately as well. There are three broad types of studies that we're going to come across. So you have your derivation studies, and these are the ones that actually develop the model that you're going to come across. They may be the ones who are combining several prognostic factors, doing adjusted regression analyses, or even perhaps doing machine learning or deep learning to develop the model. And the output of the risk of the patient is really going to be dependent on the presence or absence of the measured prognostic factors that are being put together in the derivation of the prognostic models. These guys are mostly developing, and at most, maybe they do an internal validation just to make sure that the performance metrics that they're seeing in their derivation studies is robust. Or if they go far, they actually might get another cohort that the model had never seen to do some sort of external validation. But mostly, the focus of derivation studies is to develop the model of interest. Then we have these studies that we call validation studies. And these validation studies, their ultimate goal is effectively to take somebody else's model or even their own model, take it to some completely unseen cohort that was never exposed to the model. The model development was never based on the distribution of data that was seen in that cohort, and see how well that model is performing in that external validation study. And this is where we get the most valuable measures of discrimination and calibration, because effectively, we tend to see that in the derivation studies, because you're developing your model on a given data set, there's actually sometimes overfitting, too much optimism. You think that the model performance is really good, but the model performance is really good for that particular data. And it really becomes around the validation studies where you take it to another cohort to see, does that performance that you saw in the derivation study still hold in a completely different cohort that wasn't used in the development of the model? In the world of prognostic models, there's another type of studies that we tend to come across, and these are more comparative studies. So now you have maybe 2 or 3 models for a given disease area for a given outcome, and you're trying to compare how well they're risk classifying the patients. And they tend to focus on statistics like net improvement or risk reclassification indices. And again, they're tending to focus on one model compared to another to see which is the best performing model, which is the most optimal for the given disease area for a given particular outcome of interest. Amongst all these different types of studies that we can come across for prognostic models, we're mostly focused on the validation studies. These are the studies that are reporting on the performance of the models in a completely separate cohort that wasn't used in the development of the model of interest. So again, one of the statistics that we tend to get from these is discrimination. And so discrimination is your model's capacity to be able to correctly differentiate individuals who are higher risk, who are higher risk versus the lower risk individuals for a given outcome of interest. And so the typical way that we report this discrimination statistic is, again, through the area under the receiver operating curve, or something that's called a concordance statistic. And for our purposes, for binary outcomes at a given single time point, AUROC and C statistic, they're effectively the same. You can interpret them the same. You can pull them the same. For our purposes, they're exactly the same. These numbers, they can range from 0 to 1, where 1 is a perfect discrimination, perfect separation of high and low risk patients. And again, 0.5 is one of those reference points for us, which is effectively like flipping a coin to decide who's high risk and who's low risk patients. Now, the best way to understand what these discrimination statistics are doing is to consider an example. And so the one that we tend to go to, and maybe most folks, if you're involved in clinical practice, you may have come across, is CHADS-VASc. CHADS-VASc is a model that is used to estimate the risk of thromboembolic strokes 1 year after you do the assessment on the patient. It's mostly used amongst the individuals who have non-valvular atrial fibrillation. And this model is an ordinal score, where depending on the presence or absence of prognostic factors, you can give an individual a score that goes anywhere from 0 to 9, 0 being a very low-risk patient, 9 being a very high-risk patient, meaning that they're the ones who are going to have the highest risk of having stroke in the next year after evaluation. So imagine you have 2 people. One person is for sure they've had a stroke, and the other person is a no stroke pair to that person who's had a stroke. And the 2 of them together, they make a pair of a stroke and no stroke 2 people. What discrimination is telling us is that it's the probability that your model will assign a higher score, doesn't matter how much of a higher score, it will assign any amount of a higher score to the person who had stroke as compared to the person who didn't have stroke. And it's not just the probability for these two people, it's the probability across all the potential pairs of individuals who you may come across in your data set. So one person who's had your event of interest, the other person who hasn't had your event of interest. What are the chances that the model will say the person who's had your event of interest has a higher risk? Doesn't matter how much higher, has a higher risk than the person who hasn't had the stroke. The more likely the model is to give a higher score, the higher the discrimination measure is going to be across, again, all the pairs of individuals you're going to come across in your data set of interest. Helps to visualize this a little bit. So we had these graphics and we presented this at the great meetings that we went to, and it really helped to drive home the message. What you have on the graph here, this is what we call a jitter plot, where on the y-axis, you have the status of individuals, one being those who've had your event of interest. So let's say for our purposes, these are folks who have a stroke. 0 are the people who haven't had a stroke. And on the y-axis, you have the output of your model. So this is the classification that the model can do on an individual person. And the output of the model can range, perhaps in this example, from anything between a -3 score to a +3 score, which then can translate to some sort of a probability. But just for the purposes of getting the message across, imagine this is like the ordinal score that goes from 0 to 9. Your score can go from -3 to 3. Your score can go from 50 to 100. It doesn't matter. The model is putting an output that then we can translate to some sort of a predicted probability. What you're seeing on this left-hand side is a depiction of that diagonal line on that area under the ROC curve, where I said we sometimes humorously say it's like flipping a coin to decide who's high risk and who's low risk, who's had the event, who hasn't had the event, or who's going to die, or who's going to have a stroke and who's not going to have a stroke. And it's like a flip of a coin, because if you look across all these potential classifications that the model can give a person, you can see perfect overlap between the individuals who've had a stroke versus the folks who haven't had a stroke. Doesn't matter if I say 0, 0.5, 2, -2, I can see that people are just as likely to be in the stroke group as they are to be in the no stroke group. So this is what we're really talking about when we're saying it's like flipping a coin to decide who's going to have a stroke and who's not going to have a stroke. Whereas a much better model where the performance is now at 0.95, which is close to that 1, which is like perfect separation of the people who've had your event and haven't had the event, you can start to appreciate it here, where, of course, there's some area of overlap between the folks who've had stroke and those who haven't had stroke in terms of what the model is classifying them as. But you can start to appreciate that there is ranges of people with particular scores where when this score is assigned to them, by and large, most of them haven't had a stroke. And in the higher ends of the score, we can see that if the model assigns the score, by and large, most of these people have had a stroke. So there's better separation between the people who've had the event and the people who haven't had the event. This is discrimination. This is effectively what discrimination does. And if you are used to maybe remembering some of your diagnostic lessons, we also see this in the world of diagnosis, where it's about the distribution of the test scores that are assigned to the individuals. And with 0.5, you can see that there's perfect overlap in the distribution of the probabilities that are assigned to the individuals, versus when you have 0.95, that distribution of the probabilities or distribution of the scores starts to show separation, and the 0.5, the 5% overlap or the error, you can appreciate in this region over here. And those are the folks where really, if you get this score, you don't know if they're going to have stroke or they're not going to have stroke. Now, I like these plots because it highlights an issue that we have in the world of prognosis. One thing that's often reported with these models is a global performance of the model. So when we get this 0.95, it's really hard for us to contextualize what are the consequences of this 0.95 or that 0.5%, the 5% error that comes with the not knowing if the person is going to have stroke or if the person is not going to have stroke. And the reason is that this 0.95, even though it looks really impressive, you have some regions where it's great. Like I said, in these lower range of scores, you mostly get people who haven't had a stroke. And the upper ends of the score, you get mostly people who've had a stroke. So there's no overlap between stroke and no stroke individuals in these ranges of scores. But there is a range of plausible scores that the model can assign your patients where, again, it's really a flip of a coin. Is it truly 0.95 across all these different scores that the model can assign individuals? Perhaps if you fall into this red region, your discrimination is not 0.95, your discrimination might be actually 0.5. In that specific range of scores, it's like flipping a coin to decide who's had stroke and who didn't have a stroke. But in the upper regions, it's actually more closer to an area under the ROC curve of 1.0, where it's a perfect separation. You know that if you're getting a score between 3 and 3.75, you're not going to have anybody who didn't have a stroke. All of them have had a stroke. So again, this is something that we can see once we visualize it like this, and you can talk around the consequences at different scores that the model assigns. But oftentimes, the only number that we get from these validation studies is the 0.95, which is the global performance of the model. It's the performance of the model, the best estimate across all the potential classifications that the model can assign. So how do we set up our targets of certainty rating? This was the focus of grade concept number 8, where we started to talk around inferences on discrimination, and we wanted to really model it after what people have been used to seeing in the world of therapy. So you can select, for example, these thresholds that we talk around, like the minimally important difference in the world of therapy, which tends to be some sort of absolute risk difference. And we rate our certainty in the world of therapy as to whether the effect estimate from your meta-analysis, where does it lie in relation to that threshold? Is it a small, meaningful benefit? Is it an unmeaningful benefit? Or like just some benefit, but it's not truly meaningful to most individuals? Where does the point estimate lie in relation to that threshold? We try to model it after this. Now, what could have been our potential thresholds for discrimination? There have been some historical textbooks that have said, okay, well, if your discrimination, the global performance of the model is less than 0.6, that's pretty poor discrimination. If you fall between 0.6 to 0.75, that's potentially helpful discrimination. And if it's above 0.75, that's a useful discrimination metric to be seeing in the validation study. Why these thresholds? Completely arbitrary. They have no meaning or potential context behind them. It's just something that was put together historically just to guide readers and their discomfort with trying to make sense of the measure of discrimination. You can see the textbooks that tend to rely on these. And I'm saying it was completely made up, but you know, they're pretty good statisticians behind these metrics and the thresholds that they're reporting. From our perspective in the Great Prognosis Working Group, we felt that actually it might be better to come up with 3 potential options that tend to be more helpful in contextualizing the meaning behind the discrimination measure that we're seeing. And those are, well, if you have nothing, if you have no idea, and you've just developed a model for the very first time, the simplest, which quote unquote could be like your null effect, no meaningful difference at all, or no difference between your intervention group and your control group. If you wanted to draw parallels, 0.5 would be like a null effect for us, where this is the lowest point that we care about. Anything above 0.5 is a beneficial discrimination, and you could use this as one potential threshold in making inferences on the discrimination of models. Another one is clinician's intuition. Those of you who are involved in clinical practice, you may come across patients, depending on who's in front of you, you come up with a judgment of whether or not this is a high-risk individual or this is a low-risk individual. And you yourself are a form of a model. How well you perform could be the lowest standard that we can hold a model accountable to, meaning that if the model starts to have discrimination measures that are better than what you as a clinician do, that could be one potential target of certainty rating. And another one is perhaps there may be a really well-established model for one disease area, for one outcome, And you may want to use that as your target of certainty rating to see what's a satisfactory discrimination for the next model that's going to come across that in your field of practice. And so we're going to see some examples of these in the next few slides. So to help in illustrating this, again, people have done systematic reviews on CHA2DS2-VASc, that model for stroke in individuals who have non-valvular atrial fibrillation. And their meta-analysis of all these different, at least 6 studies or 5 studies that reported on the validation or the discrimination of CHA2DS2-VASc in different cohort, what they got from it is a pooled measure of discrimination that's 0.64 with a confidence interval of 0.56 to 0.71. So what does this mean? How do we draw conclusions? If you use that first target of certainty rating, which is just random classification, 0.5, that's what this dashed line represents on this graph. So again, on the x-axis, we have the different measures of C-statistic, different measures of discrimination. We have the pooled estimate from the meta-analysis here, the 0.64 with its confidence intervals. And we can see now that because the point estimate is to the right of this line of random classification, our threshold, this measure of discrimination in relation to this target of certainty rating is acceptable. It's satisfactory. It helps in discriminating. And you, dare I say, you can actually now proceed with some other domains of your grade assessment. One that immediately comes to mind, which you may have seen from different webinars on targets of certainty rating, is that because the confidence intervals are not crossing this line, your threshold, you are quite certain in this inference that you just drew, and you don't have to rate down for something like imprecision. That's based on the 95% confidence interval of this point estimate. So again, whether this lower bound or the upper bound is true, they're giving you the same message that the model discrimination is better than random chance. Now, the second threshold that you can use is clinician's intuition. And again, clinicians can be a form of a model. And people have actually tried to evaluate this. So Steinberg in 2016, in the Orbit atrial fibrillation study, what they did was they took a nationally representative sample of primary care physicians, cardiologists, and electrophysiologists across the US. And what they asked them to do was to classify the patients as being low, moderate, or high-risk individuals for having a stroke in the next year after they came to their clinic appointment. And what they saw is that the discrimination of the patient, the discrimination of the physicians when they were forced to classify the patients as low, moderate, or high risk was 0.58 with a 95% confidence interval of 0.54 to 0.62. So you can use this 0.58 as a potential threshold to inform the target of certainty rating for CHA2DS2-VASc and whether its discrimination is acceptable. So what we have done now is we've gone from this random classification, the 0.5, to now a new target of certainty rating, which is the clinician's intuition or the physician's intuition when they were forced to classify the patients as low, moderate, or high. And again, we can see that the point estimate is to the right of this threshold. So one could say that CHA2DS2-VASc performance is acceptable with regards to discrimination. But now you can start to appreciate that perhaps you could rate down for imprecision because your confidence interval is crossing this threshold. So you might have some doubts around this inference that CHA2DS2-VASc performance is acceptable if, again, you're using physician intuition as your target of certainty rating. But be cautious. And this is something that also makes us uncomfortable. You can't, when you're looking at this, try to avoid falling into this trap of saying CHA2DS2-VASc is better than physician intuition. It wasn't a head-to-head comparison. The 0.58 that we got from physicians' ability to risk classify patients wasn't done in the same exact study, in the same setting, using the same patients as was used for evaluating the performance of CHA2DS2-VASc. It's a form of an indirect comparison, and there comes a lot of uncertainty with regards to indirect comparisons. The discrimination metrics, right, the performance of any model, even physicians, will naturally vary. If I put you in a room where everybody looks exactly the same, they all have the same symptoms, they all show up with the same complaints, they all have the same information that you're used to seeing, you're going to have a really hard time differentiating between who's going to have stroke and who's not going to have stroke. It would be also hard for models when the population looks very homogeneous. It would be very hard for the model to try to separate between high and low risk individuals, those who are going to have the event, those who are not going to have the event. So the more homogeneous the sample, the lower the discrimination. And how much one sample was homogeneous versus another sample was heterogeneous could potentially be influencing the difference between that threshold that we chose versus the point estimate that we're comparing to that threshold. So we really don't want to go into this territory to say CHA2DS2-VASc is better than physician discrimination. Again, not a head-to-head comparison in the same setting. There's a lot of uncertainty around that threshold that we selected. It had its own confidence interval. The 0.58 represents the true, perhaps it might be the best guess, but there might be some uncertainty as to whether 0.58 is a true performance of clinicians' intuition. Who are these clinicians? Are they seasoned individuals who've seen tons and tons of patients who've had stroke in the past? Or are they novice folks who just came into residency year one and they haven't seen a lot of patients? They're not having a great time being able to differentiate between the patients. Again, there is some uncertainty here, and that's making it very hard for us to confidently say CHA2DS2-VASc is better than physician intuition. And again, different contexts, different patients. There could be between study variability or difficulties in making these comparisons. So as best as possible, try to avoid making this conclusion that CHA2DS2-VASc is better than physician intuition. If you really want to, and say, because of what I saw here, CHA2DS2-VASc is better than physician intuition, you're going to have to rate down for a lot of indirectness issues. And you're going to have probably very low certainty in making the inference that CHA2DS2-VASc is better than physician intuition, which effectively, if you were to use Nancy Centesso's language around communicating what the conclusions are based on certainty, you would be throwing your hands up saying, we're actually quite uncertain about what the true difference between CHA2DS2-VASc and physician intuition is. But if you just want to comment on whether or not CHA2DS2-VASc has satisfactory discrimination, using physician intuition as a threshold for what could be potentially satisfactory, it's a satisfactory discrimination, not making comparisons. And we can talk around that a little bit. Now, if you don't have a sense of physician intuition, you're going to find this option or threshold probably a little bit uncomfortable, but we've done a systematic review of all the instances where physician intuition was compared to a model. And oftentimes we actually found that they're not that different. They're quite similar. If you don't have any evidence, you can consider the first target of certainty rating, which was random classification, AUC of 0.5, or you may consider the upcoming option, which is threshold number 3 that we're going to talk about. But you can also try to make some intuitive guess as to what your physician intuition is. And oftentimes that's what we do with thresholds. Sometimes we do surveys to inform our thresholds. Sometimes we get folks in a room and we based on our collective experience, try to think around what an acceptable threshold is, even in the world of therapy, as to what is the smallest absolute risk difference that would matter to most individuals based on our experiences. You could also, based on your experiences of how well seasoned physicians operate versus medical students, make an informed guess. But also this systematic review that we conducted, maybe you can go in there and you can find some studies for your disease area of interest, for your outcome of interest, that may have shown some evidence on what physician intuition is. But if, again, you don't want to go down this road of physician intuition, you have two other options. And so what's the third option for your target of certainty rating? That's an alternative model. So again, another model developed for the same outcome in the same disease population. But again, we're not making comparative inferences here. We're just using it to inform our threshold to inform the target of our certainty rating. So an example here is with regards to individuals who are suffering from community-acquired pneumonia and their risk of mortality being predicted by models. Chalmers and colleagues, they conducted a systematic review and meta-analysis, and they found three models. There was the CRB65, and Pneumonia Severity Index. And you can see that from their systematic review, they had done a meta-analysis for each of these models separately, different number of individual studies contributing to each meta-analysis, different number of patients. And let's say you want to now make a target of certainty rating for CRB65. Is this 0.79 acceptable or is it not acceptable? Well, what you could do is you could use the two other models for the same disease population, for the same outcome, as potential targets of certainty rating. So again, you have CURB65 in this purple dashed line. You have Pneumonia Severity Index in the red dashed line. These are now potentially two targets of certainty rating, two thresholds that you could use to make inferences around what you're seeing for CRB65. And again, because it's to the left of these thresholds, perhaps it's not a satisfactory discrimination. And because your confidence intervals crossing these thresholds, you might have uncertainty as to whether it's truly satisfactory or unsatisfactory. And that could be another potential option for you as to how you rate your certainty. So again, one thing to note here is that it's easy to fall into this trap of saying that, okay, well, CRB65 is not better than those other models. But if you go back to the slide, they're not all exactly the same studies. They're not all exactly the same patients. There may be differences between them, important differences that may show what the results that it's showing. But we're just using this 0.8 or 0.81 as targets of certainty rating to make some conclusion around 0.79 being acceptable or unacceptable, and then proceeding with the rest of our grade assessment. So try to avoid saying better or worse as much as possible. And if you do, you have quite a lot of uncertainty. So I know that we have about 14 minutes left, and I think the plan was 40-minute talk, 20 minutes for questions and answers. I think maybe if I were to say main takeaways from concept paper number 8, discrimination is, what are we rating our certainty in? And we have three options that we came up with for grade concept number 8, which was random classification, physician intuition, alternative model. And for options 2 and 3, again, be cautious not to say it's superior or inferior. It's just satisfactory or unsatisfactory discrimination based on what you're seeing in relation to where the threshold is. Reem and Madeline, Philip, is it or San, is it good to stop maybe here and give time for questions to folks?
Yes, Fareed. Thank you very much for this quite comprehensive overview of not only the methods of assessing certainty, but also different study design used in this area and some of the major challenges. So thank you very much. I'm actually gonna open it up for questions. There are none in the chat so far, but I'm sure.
I have a question. Maybe I
Yes,
can
Hassan, please go ahead.
start. So, can you describe in the big picture of grade where these concept papers and guidances are? Because there is guidance 28 and 30 for prognostic studies and for model, and then you have these two concept papers. So, if you can just kind of say where do these fall in grade, like in an actual guideline project?
No, it's a great question, Hassan. And in prognosis, there are three different types of questions that you could be asking. And well, actually there could be more, but the three main ones is you could ask overall prognosis questions, which is the BMJ prognosis grade guidance that was led by Alfonso Iorio, came out in 2016. It's our only prognosis guidance paper that's in the BMJ. And then you can ask questions around prognostic factors and how certain you are on the measures of associations between prognostic factors and your outcomes of interest. Those are what's covered in Guidance 28. And these two concept papers are the precursors to official grade guidance that's going to come out on how do we rate our certainty on discrimination and calibration. But before we go to talk around domains of risk of bias, inconsistency, and precision, indirectness, publication bias, we always need to figure out what our target of certainty rating is in relation to all other types of grade assessments that we do. And these two papers, grade concept number 2 and 8, they help the audience become accustomed to the concepts of discrimination calibration and how we set up our targets of certainty rating before we go through the individual domains of grade assessment.
And in an actual guideline,
Mhm.
you're seeing this as a step to determine certainty in a specific baseline risk?
Yeah, yeah, so with regards to this modeling work, the prognostic models, you may come across a disease area where you have several different prognostic models that are available. So Reem and I, we did this guideline with the BMJ Rapid-Rex, and it was on diabetes medications. And the panel wanted to know, what are our options for risk classifying our patients? Which model should we rely on? Because they knew that there were several models in that area. So we don't have official grade guidance, but these principles in concept number 2 and 8 helped us to digest the body of evidence that we got from a systematic review of all the prediction models that are available for patients with diabetes. And then based on the findings of that review, we were able to tell the panel, Recode, which was the name of the model, is the best performing model. It has the highest discrimination, best calibration, and we have the most certainty in the estimates of the discrimination and calibration that we can bring to your attention and inform you. And then they use that model to get different estimates of baseline risk that they put into their summary of findings tables to put it together with the evidence that came from the network meta-analysis of all the different interventions. Reem, your recollection is the same as mine.
Yeah, Farid, no, exactly. To kind of summarize it, panels may be asking which model should we use. You can use this guidance to decide which of the multiple, models, prognostic models out there. They may be asking which risk factors are critical in decision making. You can assess certainty, and the prognostic guidance, guidance about prognostic risk factor would help you. Or they may be just simply using all that information to decide baseline risk. All these are areas where you can actually utilize this work and guidance in guideline panels. There are two very great questions in the chat. So the first question is, can you speak to a number of participants involved in these validation studies? Is there an accepted number that is optimal to evaluate? And this is coming from Anitra Graves.
Oh, it's such a good question. And so there are risk of bias tools for this. And we didn't really go into individual domains of grade, but if you were to use a tool, it would be Probast, assessment of bias in prognostic models. And Probast does actually ask questions around the conduct of statistical analysis and the design of the studies. People have done sample size estimations for validation studies on prognostic models. It's really hard because you're not doing any sort of a comparison. It's not a statistical test of a comparison. It's a test of, it's not actually a test, it's just an estimation procedure. So how certain are you in that point estimate that you're producing from the individual validation study? And they found that as long as you have 100 outcomes, then you have sufficiently narrow confidence intervals, and they're actually closer to the ground truth from which they subsample different types of cohorts at different event rates. And with 100 events, when the sampling was done such that there were 100 events, that was the closest to the population from which they sampled. and it was the closest in terms of the ground truth for the model performance. So
Right.
was the sample size is just 100 events.
And in relation to that, I think Anitra is also asking if there is a relation between the prevalence of disease and the output of the diagnostic model, or risk stratification versus diagnosis. And is there is risk stratification, I would imagine better validation would require more participants in relation. So 100 events, which would have to relate to the prevalence one way or the other, right?
Yeah, and when the prevalence of the outcome is pretty low, or the risk of the outcome is pretty low, then it's a much harder task to actually try to validate the model in that sort of a setting. But discrimination, again, like it's not so much around the prevalence. What matters the most for variability and discrimination is the dispersion of the sample. So if you have a very homogeneous cohort, you tend to see lower discrimination. When you have quite nice heterogeneity in the types of patients that come into the cohort, that's where you have the nice ability to actually truly evaluate the model. The similar sensitivity and specificity, they're not really driven by the prevalence of the disease, but it's rather the positive predictive value and negative predictive value that are affected. This is your territory. I'm just pretending,
Well,
but yeah.
This is a perfect segue for Carlos Diaz's question, which is about, are these recommendations also applicable to diagnostic predictive models?
We had a lot of thought around this. Where we suffer in the world of prognosis is that we get that global performance of the model. Where I think where folks in diagnostic world are a little bit better is they actually try to not just say, this is a diagnostic model, we've developed it. They actually try to talk around thresholds above which you're test positive, thresholds under which you're test negative, and then you can have nice sensitivity, specificity, consequences of false positives, consequences of false negatives that then can help you in contextualizing the decisions that you end up making based on the classification that's done by the model. We're way behind in that because people are not really sure how to use model. And perhaps that's actually a philosophical question as to why sometimes models are not used that often in practice, because people don't know what to do with the output of the model. Above what probability should you treat? Below what probability you shouldn't treat? And I think when we start to marry a model more closely with a guideline recommendation, perhaps then we can start to have these conversations around, now can we, rather than having a global AUC, get one specific measure of discrimination that's around that output of the model that determine who's going to be treated, who's not going to be treated, who's going to get this recommendation versus who's not going to get that recommendation. So there are some parallels, but I think the diagnostic world is a little bit further ahead as to what they do with the evidence that they get on their diagnostic models.
Great. Thank you so much, Fareed. We have time maybe for one more quick question before we adjourn. I think, Fareed, I'll ask that, maybe concluding question. You did allude to it, but what's coming next with the grade prognosis working group?
Yeah, so right now we're just going through lots of examples of different systematic reviews that have validated prognostic models to formulate clear guidance on what to do with risk of bias, what to do with inconsistency, indirectness, publication bias, and not just for discrimination, but we're also doing it for calibration, which we didn't really have a lot of time to go through. So stay tuned for that guidance to hopefully come to grade, and if it goes through grade approval, then it'll be official grade guidance on how to do grade assessments on discrimination and calibration. And then after that, we really need to start to talk around how do we put this evidence together with the evidence of therapy, and how do we handle the uncertainties that come from both? Should we ignore uncertainty in prognosis because then grade is always downgrading too much and saying we're always uncertain, or is there an effective way that we can account for uncertainty from prognosis and uncertainty from therapy. We really have no idea what we're doing there, but perhaps that could be future work that we're all tackling together.
That's great. Fareed, again, thank you so much for this very thoughtful and comprehensive review of the topic. A lot more to come. And for everybody on here, if you have examples, I'm sure Fareed and us all would love to see those examples and work with them. With that, Madeline, I'm going to hand it back to you.
Sure. Thank you, Raymond. Thank you so much, Fareed. This was really enlightening and very much appreciated. Just a last reminder. So if this was of interest to you, right, if you're in this webinar, there's something about prognosis that is of interest to you. Great news is that our virtual workshop is a special focus on prognosis and grade. So if you'd like to join us, just a reminder, you can register at the link at gradeconf.org that I've put in the chat. And finally, we do offer scholarships for folks to attend our workshops free of charge. And so if you're interested in learning more about that, our applications close next Sunday. So you still have a week to apply. So you can find the link in the chat as well. Thank you all so much for joining, and we hope to see you at the next one in October. Thank you all.